As some of you may be aware, in the fall of 2011, the South Carolina Joint Citizens and Legislative Committee on Children recommended action on safe sleeping for infants as a focus area for state efforts and resources. The number of infant deaths in South Carolina due to accidental suffocation and strangulation in bed had more than doubled since 2004. Children's Trust was asked to take the lead on this initiative, and we convened representatives from more than 20 different areas of expertise: medical, nonprofit, educational, and public and private agencies. An important part of the work was that the coalition recommend all safe sleeping curriculum, training, and education materials be based on the American Academy of Pediatric guidelines. At the heart of those guidelines, as many of you know, infants should sleep alone, on their backs, in a crib, without any loose objects or loose bedding. Our next speaker, Dr. Rachel Moon, will help us learn more about the American Academy of Pediatric recommendations, look at the difference between sleep-related deaths and sudden infant death syndrome, or SIDS as some people know it, and help us to understand some of the important statistics that went into those recommendations. Dr. Moon's credentials are very impressive. She is an internationally recognized expert in sudden infant death syndrome and serves on the SIDS task force at the American Academy of Pediatrics. She currently is the Director of Academic Development for the Goldberg Center for Community Pediatric Health and Children's National Medical Center in Washington, D.C. She earned her undergraduate and medical degree from Emory University in Atlanta and completed her residency at the Children's Hospital of Philadelphia. And she has also served as a pediatrician in the Air Force. Join me in welcoming Dr. Moon. Thank you.
Good afternoon, everybody. I have to say that it's a little bit daunting to come up here after the two plenary speakers that you had this morning. And I apologize in advance. There's no dancing in this session. So I really apologize. Had I known that that was the expectation, I would have put something in there, but I apologize. So what I'm going to do over the next 45 minutes, I'm going to talk about safe sleep and about SIDS and how we can keep the babies safe. So these are the topics we're going to talk about. So we'll talk about SIDS, sleep-related death. We'll talk about why these babies die. We'll talk about statistics, and then we're going to spend most of the time talking about the recommendations, and more importantly, the rationale behind the recommendations, because I think it's really important for people to understand why before they understand what. So just some definitions to start with so that we're all on the same page. SUID, it's really confusing. I feel a little schizophrenic. There's a screen there, there's a screen there. So I'm just going to try to do equal billing, but if I seem like I'm spinning, then just somebody raise your hand and tell me to stop. Okay, so SUID is exactly what it sounds like. Sudden and unexpected infant death. So it's when a baby, less than 1 year of age, which is what we call infants, dies suddenly and unexpectedly. Some people will call it SUID, which is sudden and unexpected death in infancy. So you'll hear both of those terms bandied about. And this is, so you have SUIDs, and then there are explained SUIDs, and there are unexplained SUIDs. And under explained SUIDs are things like trauma, drowning, car accidents, something that's known diagnosis like a cardiac disease or something like that. And then you have accidental suffocation, which is important to us because that's one of the sleep-related deaths, but that's something that ultimately is explained. And then in unexplained, you have the SIDS, and then you have the undetermined. And undetermined is when you have a death and the coroner or the medical examiner isn't quite sure what happened. So it looks like a SIDS, but the baby was bed sharing with the parents. Or it looks like a SIDS, but there have been 2 other deaths in that same child care center in the past couple of years. So it's when there's a little bit of uncertainty and the coroner or the medical examiner can't quite pin it down to one thing, so then those are the ones that become undetermined. And the ones that we are talking about today are the accidental suffocation, the SIDS, and the undetermined. And those are what we call sleep-related deaths because most of them occur when the baby is asleep or when the baby is in a sleep environment, such as a crib or a bassinet or an adult bed or something like that. And the things that, so we have this suffocation. We also have strangulation and entrapment that goes in with that. And then we have the undetermined, some people call it ill-defined, some people call it unknown, and then the SIDS. So then what is SIDS? So SIDS is any SUID that remains unexplained even after there's complete review of the history, an autopsy, and a death scene investigation. So typically, it's a seemingly healthy baby who's found dead after a sleep period, and they either died during sleep or during a transition from sleep to waking. Now, what is suffocation? So here's some more terms. You guys are going to think you're going to feel like a dictionary by the end of this. So asphyxia, you'll hear this term, is any situation where there's a decrease in oxygen or an increase in carbon dioxide in the body. And as you remember, all of us breathe in oxygen, we breathe out carbon dioxide. So if you have too much carbon dioxide, that's bad. If you have not enough oxygen, that's bad. So asphyxia is what happens. It can happen when you stop breathing. It can happen when something becomes obstructed, your airway becomes obstructed, somebody pressing on your neck or on your nose or in your mouth so you can't breathe. If you rebreathe, so imagine a baby face down in soft bedding, they're going to be rebreathing that carbon dioxide that they just breathed out, and they're not going to be getting in any fresh air. Any fresh oxygen. So that's what asphyxia is. Suffocation is a form of asphyxia. And entrapment is when a baby is trapped between two hard objects so they can't get enough, so they can't breathe. So for instance, the baby is trapped between the headboard and the wall, the headboard of an adult bed and the wall, or the mattress and the wall, or the mattress. It often happens with an adult bed that's against the wall, or a couch that's against the wall. So it's when a baby is trapped in that kind of situation. And then strangulation is when something is wrapped around the neck, causing the baby, causing airway blockage. So it doesn't take a lot of pressure to completely obstruct a baby's airway. You just press on their airway just a little bit, and that'll do it. So asphyxia has always been a part of SIDS. Okay? And there are a lot of risk factors that are associated with environments that are potentially asphyxiating for children. That's why these are the risk factors. So prone sleeping, soft bedding, pillows, bumper pads, all that kind of stuff, bed sharing, all of these things are environments that could potentially cause asphyxia in a baby. There's some asphyxial situations that would cause death in any baby. So for instance, that baby who was trapped in between the mattress and the wall, that kind of a situation any baby would die in. But there's some situations where not all babies die. So why is that? Why is it that some babies die and some babies don't when they're in that situation? So we have this triple risk model, which many of you have heard about, and you have three different things in this Venn diagram. First is you have a vulnerable baby. And this vulnerable baby is vulnerable because there's something going on in their body that makes them vulnerable. And we think that for most of these babies, it's that they don't wake up, that they can't arouse. Okay? So there's a defect in their brainstem that keeps them from waking up when they're supposed to wake up. And then you put that baby in a critical period, during a critical period, and we know that the highest risk for SIDS and for all of these deaths is less than 3 or 4 months of age, and the highest risk is between 2 and 4 months of age. And then if you have that baby in that critical developmental period, and then you stress that baby by putting the baby on the stomach or on the side, exposing the baby to smoke, bed sharing with that baby, putting the baby in a crib with bumper pads, these are things that can stress the baby, cause an asphyxial situation, and you get this whole conglomeration, this perfect storm, and you get a baby that dies. Another way to look at it is you look at a combination of genetic factors and behavioral and environmental factors. So this is no different than a lot of diseases. So if we take adult cardiac disease, heart disease, for example, what determines whether or not you have a heart attack? Well, there are going to be genetic factors, okay? So do you have a family history? So is there something going on in your family? Do you have hypercholesterolemia because it's a familial thing? So high cholesterols have run in your family. So there are genetic factors, but then there are all those behavioral factors as well. Do you exercise? Do you weigh 500 pounds? Do you eat fast food 3 times a day? Okay, those are the behavioral things. So there are some people that do everything right. Okay, and you've heard about these people, the marathoner that dropped dead of a heart attack. And everybody goes, oh my God, you did everything right. Okay, but for that person, the genetic factors were so overwhelming for him that even though he did everything right, it was still too much for him. Okay, then you have people that are the total opposite, where there are no genetic factors, but they're not watching their weight. They aren't exercising. They're smoking 3 packs a day, all of this kind of stuff. And so they may not have genetic factors, but the behaviors overwhelm their body and they die. Okay? The same is true with SIDS and all of these deaths. You can have genetic factors that are so strong, you can have such a bad arousal defect that even though your parents have done everything right, you could still die. It doesn't happen very often, but these are the ones that we always hear about. Oh, that baby died on his back. And so that means the back isn't good, right? Because you hear about that exception, and so that means that you don't have to follow the rules. Okay? And then on the other hand, you may have a baby that has none of these problems, but is in one of these situations where they can't escape and that anybody would die. So they're getting strangled or they're suffocating or something like that. Okay? And so these kinds of things, so SIDS is not unlike a lot of these other diseases that we're used to. It's this interaction between the environment and the genetics. But sometimes one or the other can be more important. And for us, we can't really do anything about the genetics, so where we can impact is on the environment and on the behaviors, and that's what we're trying to do. And I know that I'm a baby boomer because I'm telling you this and I'm not giving you an option, but that's just too bad. So our current hypothesis is that SIDS results when a vulnerable baby cannot adequately defend against an asphyxiating environment, which is a level of asphyxia where most babies would not die. So the rebreathing theory tells us that babies in certain sleep environments are more likely to trap carbon dioxide around their face. So if you're lying on your stomach in a face down or near a face down position, and there are a lot of babies that like to do this, you can just imagine, particularly if there's soft bedding there, that there can be this pocket of carbon dioxide around your face. Okay? If there's soft bedding, if there's tobacco smoke in your environment, or you've been exposed to tobacco in utero, we know that you are more likely to rebreathe. It's just that it's because your brain and your lungs don't develop quite as well, and so that's a defect that's there for babies of smokers. And so if you rebreathe the exhaled carbon dioxide, if you do not wake up and if you do not respond appropriately, you will die. Hannah Kinney is a neuropathologist up in Boston, and she and her group have found some neurotransmitter abnormalities in the brainstem in babies who die suddenly and unexpectedly. And these are neurotransmitters. A lot of it has to do with serotonin, and it's this whole network dysfunction. And the interesting thing is that some other scientists have found polymorphisms or little mini changes in the serotonin transporter protein gene, so that the babies that are more likely to die, the babies who have died are more likely to have the genes that make it so that there's less serotonin floating around, which kind of fits with the pathology findings as well. And up to 70% of the babies who die have neurotransmitter abnormalities, and these abnormalities are not present in other babies who die from other causes. So this is just a picture of the brainstem down here, kind of. Let's see, is this pointer working? No. Oh, it just doesn't go that far. So over on the right, you have all of these different components of the brainstem and all these different neurotransmitters, and you can see that it affects upper airway breathing, it affects the lungs, it affects the heart rate, it affects blood pressure, it affects all of this kind of stuff, and it also affects, the brainstem also affects sleep and arousal. And so again, if you're not arousing, then that's a problem. So again, you have this whole triple risk model, and some things are filled in. So there are things that can make you more vulnerable. So we know that smoking is going to be a problem. We know that alcohol and illicit drugs, I didn't talk about that much, but that can be a problem. If you're premature, if you have growth restriction, those all make you more likely to be vulnerable. And then the risk factors and the critical developmental period as well. And then if we kind of fill this out, we know that there are all of these different things on the left-hand side, the smoking, the race, ethnicity, all of those things that are behavior. Well, actually, race, ethnicity isn't behavioral, but prematurity, prone sleeping, all of those kinds of things. And then we know all of the genetic things over here on the right, and these are just some of the ones that we know of right now, and that list is just growing and growing and growing. Okay, so what we have, when you have a baby that dies from SIDS, you have a baby that's in a sleep environment, and there can be a range. On the left is non-asphyxiating, okay, and on the right is very asphyxiating. So there's combinations of, and there's a spectrum throughout that. So is the baby on the back? Is there bedding? Are there bumper pads? Is the head covered? Is there bed sharing? All of those kinds of things determine how asphyxiating or potentially asphyxiating your sleep environment is. The other thing that you have is the baby. So how vulnerable is that baby? The ones on the left are very vulnerable. The ones on the right are not vulnerable. So if you have a baby that's in a severe asphyxiating environment, even though that baby is totally normal, these are the ones that are the strangulation, the overlay, the entrapment, the ones that no baby could escape from, okay? So then the ones on the very left, those are the ones that have the brainstem dysfunction, and those are the ones where they did everything right, okay? And so those are pretty easy to make a diagnosis of, okay? But there are interactions that can occur anywhere along this continuum. So you can have a kind of normal baby with a little bit of a vulnerability who's in a non-asphyxiating environment. So there are interactions that occur all over that area. So when you think about the cause of death, and I'm sorry that this doesn't come out so well. Over on the very left, it's very easy to say that that's SIDS, because that's pretty clear cut. And over on the right, it's very easy to say that that's accidental suffocation or strangulation, because that's pretty clear cut. But in the middle, where do you draw the line? When does SIDS become suffocation? When is suffocation SIDS? When is it undetermined? It's really hard to know, because the person who is making the determination of what that cause of death is the medical examiner or the coroner. And the only information he or she has is the information about the sleep environment. That person doesn't have the information about the infant and the vulnerability, because there's no way for us to know that at this point in time. So they're making this cause of death determination a little bit almost half blindly, and they're doing the best they can, but that's why you can have a baby who dies, one person will say it's suffocation, one person will say it's SIDS, and there's a lot of confusion, and that's why, because people are trying to do the best they can and make the best determination they can, but they're working with not all of the information. Okay. The key to this, though, is that even no matter what causes the death, it's the same risk factors, okay? So if you can get babies to sleep on their back, if you can get the bumper pads out of the crib, if you can get people to put babies in their crib, you're gonna get rid of all of this stuff, okay? Whether it's SIDS, whether it's undetermined, whether it's suffocation. So that is the key point to this. So a safe sleep environment can reduce the incidence of both SIDS and accidental suffocation. And I think that rather than get caught up in the terms, I think that we all have to look at the big picture of that. Okay. So just looking at SIDS rates and sleep position, the rates of, since back to sleep started, which is when the green line started, rates of SIDS have gone down, percent back sleeping have gone up, but we've only gotten to about 70% or 75%, and we can't get up any further than that. And then what's happening now is that we're getting these other deaths, the ones that are up on the top of the bars. ASSB is accidental suffocation and strangulation in bed, and the other bar in the middle is ill-defined, and I apologize that the colors don't come out so well. But those numbers have gotten bigger. And so the overall post-neonatal mortality hasn't changed in the past 10 or 20 years because there's a little bit of a diagnostic shift going on because people are doing better death scene investigations. We're learning more about the environment. And so things that used to be called SIDS are now being called something else. This is a graph of accidental suffocation and strangulation deaths, and they've skyrocketed in the last decade. They've gone up 4 times. So what's the problem? I think that the problem is everybody thinks that his or her child is the exception to the rule. Okay? So my baby has reflux, so he doesn't need to sleep. He can't sleep on his back. My baby is premature, and the nurses had her on her stomach. My baby is a bad sleeper and can't sleep on the back. How many people have heard those kinds of things? Just about everybody, right? So everybody thinks that they're an exception to the rule. So when we wrote the revised statement, we wanted to be more concrete, more explicit, explain what were the true exceptions and what were not, and make it easier for people like you who are out there on the front lines advising parents and providing guidance to families. So in general, when you look at the recommendations, we've expanded them so that they're to reduce the risk of SIDS and sleep-related suffocation, asphyxia, and entrapment. And you should use the recommendations to 1 year until 1 year of age. And why is that? Because when you do these studies, it's case control studies. Okay, so you're comparing babies who died from SIDS versus babies who died from everything or who didn't die. And babies who die from SIDS, you can die from SIDS up to 1 year of age. So that means if you match each baby who died with a baby who didn't die, there are going to be babies who are almost 1 year of age in both groups. And so because it's all the way up to a year of age, we can't look at the studies and say, oh, well, you can do it up until here, because the studies just don't tell us that. Having said that, I think it's most important in the first 6 months. And if in the last 6 months people are becoming a little bit more lax, I don't worry about it quite as much. But the recommendations are, we do recommend them until a year of age. There are 2 documents. One is a policy statement, which is a summary of the recommendations, and the technical report, which has all of the background information and the literature review, and it has about 300 references to it. So if you need any references, that's where to go. So to blitz through the different recommendations, the first one is one that you're all familiar with, back to sleep for every sleep. So that's nap time and nighttime. And we do not recommend safe side sleeping because it is not safe. And I'll tell you why. Multiple studies have shown that side sleep puts you at higher risk than the back position, and the most recent studies show that side sleeping is just as dangerous as stomach sleeping. So if you think you're doing parents a favor by saying that they can put their babies on the side, you're not, okay? So it is unstable, and babies, if they're on their side, are more likely to end up on their stomach. And we know that those babies, the ones that are the unaccustomed prone, have the ones that accidentally roll into the prone position are the ones that are at the highest risk for SIDS. Okay? So you don't want to put them on their sides. But why do people put them on their sides or on their backs or on their stomachs? One is people are worried about choking and aspiration, right? Okay, everybody worries that their baby's going to choke. So a couple of things that I want to say about this. One is, when do you think that a baby's choking? How do you know that a baby's choking? You can hear it, right? They go like that, right? Okay, that is not choking. That is your gag reflex. Okay, so that is the baby intentionally trying not to choke and making themselves not choke. So they're protecting their airway. That noise is the fact that noise is telling you that that baby's airway is protected, not that anything is going wrong, okay? So that's the first thing, and people think that people misconstrue that for being actual choking, and they flip out. Second thing is people worry about GE reflux. Okay, what percentage of babies reflux? I hear 90%? I hear 100%. Yeah, so what is reflux? Reflux is spitting up. Has anybody ever met a baby who didn't spit up? I would like to meet that baby. You know, I was the mom who walked around every day with spit up on her shoulder and nobody told her. And I pretty much only wear dark colors, black and blue, and so I never wear peach or things that it might blend in with. So, that was me. Okay, so every single baby spits up. Okay, so that is not an exception. So the other thing is And if you take away nothing from this talk, this is the one you should take away, okay? When you are on your back, your trachea, which is your airway, is on top of your esophagus, which is your food pipe, okay? So when you spit up, the food comes up your esophagus, and then it has to go up against gravity to go into your lungs through your trachea. If you are on your stomach, the esophagus is on top of the trachea, and there's no resistance going into your airway, into your lungs. So anatomically, it is easier for you to aspirate if you are on your stomach. Okay? So draw a picture for the parents, show them this. It's like, oh, that makes sense. That really makes sense. Okay? So, and we know also that just from other studies that have been done, not just the anatomical things, that if you put a baby on the back, it does not increase the risk of choking, even for those babies who have reflux. So you should be placed on your back if you have reflux. The only exception is if you do not have a gag reflux, okay? Or if you have an airway where your gag reflux is impaired, okay? And these are like 1 in a million babies. These are things like, I don't even remember. Oh, type 3 or type 4 laryngeal cleft that has been unrepaired. Has anybody seen a type 3 or type 4 laryngeal cleft? Okay, I think that we have one person. Okay, how many have you seen? Okay, you saw one in Korea? Okay. Okay, so we probably have 1,000 years of experience here, maybe more. Okay, and we only have one case. This is a truly rare exception. Okay, so the North American Society for Gastroenterology and Nutrition, these are the reflux experts, okay? They say that babies with reflux should be placed for sleep in the supine position, except, again, for the rare baby for whom the risk of death from complications of GE reflux is greater than the risk of SIDS. Okay, so these are, again, the babies where the airway is unprotected. Okay. So what about elevating the head of the crib? Have people seen that? Yeah, okay. So it doesn't work, okay? The studies that were done on this were done on babies that were on their stomachs. If you're on your stomach and you elevate the head of the crib, then it does help a little bit. If you're on your back and you elevate the head of the crib, it doesn't do anything. Okay, and we want these babies on their back. The other thing is that when you have a baby on their back and you elevate the head of the crib, unless you Velcro that baby to the crib, that baby's going to slide down. Okay, and that when babies are not really graceful when they slide down. So when they slide down to the bottom of the crib, they're going to be all kind of scrunched up. Okay, and when you go like that, if you're a little baby, that's enough to compromise your airway. Remember, it just takes a little bit of pressure to block that airway, and that can put a baby in an asphyxiating situation. Okay, car seats. Who's seen babies in car seats because of reflux? It makes it worse. Okay, the studies have shown that it makes it worse. The other thing, because what's happening is that you put this baby in this car seat, and there becomes this kink right in where their stomach is, because they're bent. Okay, and that makes them reflux more. So the other thing is that we see babies who fall out of car seats because people put them on the table, and then the toddler sibling goes rushing by and goes, "Wah!" and the baby goes flying. So don't put them in the car seats because it doesn't really help. Okay, so who's heard this? The baby sleeps better. Anybody? Nobody? Oh, yeah, okay. So this is the other reason that babies are being placed on their stomach. And we know that this is true. Babies who are on their stomach, they have higher arousal thresholds. So it takes longer to wake them up. So they sleep longer, they sleep more deeply. But then what's the problem with that? They're not arousing, right? And that's the whole thing with SIDS, okay? So actually having them sleep better is not a good thing, okay? So I think we really do kind of need to change the definition of what a good sleeper is, okay? So a good sleeper to me is a baby that wakes up every couple of hours, whether it be a feeding or not, and then can put him or herself back to sleep. Okay, it's not a baby that sleeps for 8 hours without waking up. Okay, that baby is one that I'm worried about because I'm worried about that baby's arousal capability. Okay, but this is a big thing. This was in the New York Times a few years ago, and it's still true, that all across the country, parents like Ms. Sancho are mounting a minor mutiny against the medical establishment. Since new parents are finding out that the benefits of having babies sleep soundly more likely when they sleep on their stomachs outweigh the comparatively tiny risk of SIDS. Okay, so people are making this kind of risk-benefit ratio calculation in their head every single day. Okay. So what about preterm babies? Preterm babies also need to be on their backs. We know that they are more likely to be put on their stomach, particularly initially because on respirators and things like that, but they're more likely to sleep prone after their discharge as well. But we know that prone sleep position and SIDS, that association for low birth weight and premature babies, is even stronger than for the term babies. So we want them on their backs, but they have to learn how to be on their backs. Because you can't just have them on their stomach the whole time in the nursery and then say, okay, put them on their back. It's not going to work because it takes a few weeks for the babies to learn how to sleep on their backs. So you want to put them on their backs as soon as the baby's medically stable and significantly before the infant's anticipated discharge by 32 weeks gestation. Okay, so that's the neonatologist. That was their recommendation, that they felt that almost every baby by 32 weeks should be able to be on their back. And certainly there are going to be exceptions to the rule, but again, those are very, very rare exceptions. Babies in the newborn nursery are often placed on their side, again, because there's this perception that babies are going to spit up this amniotic fluid and that they're going to choke on it, okay? The problem is, it's probably fine and it's not a big deal, except that if a parent sees that, then they copy that. Because if they see you doing it, then what are they going to think? It doesn't matter. If the nurse is doing it, if the doctor's doing it, if the lactation consultant's doing it, they know what they're doing. And if they're doing it, either it's not important, I'm the exception, right? And so I don't have to do it. Okay, so we want them to be on the back as soon as they're ready to be placed in the bassinet. And yeah, because there's no evidence that it actually helps with putting them on the side makes any difference with aspiration. Okay, how about rolling over? There are no data about when it's safe to let them roll over and stay laid over. Stay laid over? That's not right. Stay rolled over? Okay, stay in the position that they rolled into. You still want to put them on their backs until they're 1. And then once they can roll comfortably both ways, I'm okay with, if they roll, that they stay the way that they rolled into, as long as you make sure everything is out of that crib, okay? Because the worst thing is when a baby rolls over and rolls into a bumper pad or rolls into a pillow and gets stuck and can't get out. Okay. Moving away from sleep position to firm sleep surface, you want them on a firm sleep surface, firm mattress, fitted sheet. Use a mattress designed for the product, and you want it to maintain its shape even when you put a fitted sheet on. So if the mattress goes like that when you put the sheet on, that's probably not so good because there are going to be gaps in there. Don't put pillows or blankets in addition to or instead of the mattress under the baby. This is what a lot of parents will do. They'll think the mattress is too hard, and then they'll put a pillow or a blanket on top, and then they'll put the sheet on top of that and wrap it tightly. And because it's tight, they think that's firm. Okay? Ask your parents. I bet you some of them are doing this, okay? Because you tell them firm mattress, and that's what they think. They don't think firm is hard. They think firm is tight. Okay. Sitting devices, we talked about this a little bit. We really don't like the sitting devices, particularly for the babies less than 4 months of age, again, because they get into these positions where they can become asphyxiated and airway obstruction. Slings, you want to make sure the baby's up, their heads are up so that you can see them, because again, they can get into problems when they're down in the sling. And then if a baby falls asleep in one of these devices, then you want to move them into a crib or another appropriate flat surface as soon as possible. Because this can always happen. Okay. Okay, so then soft bedding. See, I told you I wouldn't have you dance, but I didn't promise I wouldn't make you laugh. Okay, so soft bedding. Why do people use soft bedding? Number one, it's comfortable. And how does a parent decide that it's comfortable? Because the parent thinks that it would be more comfortable. And sometimes because they say that the baby will sleep better, okay? But really, you know, the way that I describe this to parents is that a baby, you know, if they're lying on a soft surface, they're kind of struggling to keep their head up, okay? And to try to maintain some equilibrium there. So a firm surface is actually going to be more comfortable for the baby. People also use soft bedding because of safety, because people have this idea that if it's soft, it's going to cushion bumps. And this is really true for bumper pads in particular. Parents worry that babies are going to get cold. And then the biggest thing is that it looks nice, and it's cute, and you're supposed to buy it. And if it wasn't safe, the stores wouldn't sell it. And we know that's not true. But you know, soft bedding increases the risk of SIDS fivefold, depending, no matter what position you're sleeping in. If you are sleeping on your stomach and soft bedding, your risk goes up 21 times. The Consumer Product Safety Commission has reported that the majority of their sleep-related infant deaths are due to suffocation involving pillows, blankets, and extra bedding and quilts. So this is a picture of a baby. And you can just kind of, or a doll, you can just imagine kind of a pocket of CO2 around that baby's face. This is another baby. Pillows are a huge issue. Most of the babies that die with pillows are prone. They're put on top of a pillow or they roll into a pillow, and the vast majority of them are less than 4 months of age. So again, keep the pillows outside of the crib when the babies are sleeping. Again, bumper pads, people do use bumper pads because of safety and because they're cute and because you're supposed to buy them. So they worry that the baby's going to hit the head. They worry that the baby's arm or leg is going to get stuck. They worry that the baby's going to scoot into the corner. And they worry about bruises. They worry about social services coming after them. But, you know, a lot of babies die against bumper pads. And they're for 3 reasons. One is that the soft pillow-like ones they suffocate against, or the hard ones they get entrapped in between the mattress and the bumper pad, and then they can also strangle from the bumper pad ties. And the studies have shown that bumper pads do not prevent injury, serious injury in these babies, because the young babies, the ones that we're worried about, the less than 4 or 5 month old babies, you can't generate enough force if you're that little. I mean, you only weigh 10 pounds. You know, you can't fling yourself across to you know, really do damage, okay? So if you roll into the crib side, you're gonna go bonk, and you're gonna go, wah, you know, but it's gonna be okay. Really, it is. If your arm or leg gets stuck, it's distressing. The mom's going to probably cry, but you take it out and it's okay. You know, as opposed to having a baby die, which, you know, is just devastating. And I don't mean to make fun of parents, you know, for wanting the best for their kids, but sometimes, and I know this because I'm a type A parent, although I think I'm getting better, but don't ask my kids because they'll tell you something different. You want the best for your child. You want your child to be safe. You want your child to be happy. Those are the 2 things you want. Okay, and a lot of the stuff that's out there is created and is to try to feed into those 2 desires. But those 2 desires are sometimes not compatible. Okay, and every once in a while, it's okay if your baby cries. It really is, because in the long run, it's a safer thing. It's a better thing. Okay, you know, if your child cries because she's not going to get her 3rd ice cream cone, that's okay, you know? It's the same kind of thing. The other thing that we found is that in our focus groups with parents is that parents will not put babies in cribs if there's a bumper pad in there because they can't see the baby. So they'll keep the baby in the bed with them where they can watch the baby. So if you take the bumper pad out of the crib, then it's magical. You can see the baby. Okay, so again, this study showed that the potential benefits for preventing minor injury with bumper pads was far outweighed by the risk of severe injury. So here's a baby that got stuck in the corner, okay, couldn't get out, became entrapped. Okay, so the other thing, there's no evidence that, like I said, that these help, and so we don't recommend them. So you want to get everything out of the crib. Basically, the only thing you want in the crib is the mattress, a firm, the sheet, and the baby. That's it. You can use sleep clothing, wearable blankets as an alternative. The other advantage to these wearable blankets is that then the baby's leg doesn't get stuck in between the slats. Okay, bed sharing. Am I okay with time? 5 minutes? Okay. A couple of things about bed sharing. Bed sharing is different from co-sleeping. Co-sleeping is when a baby and the parent are in the same environment close enough that they can see, hear, or touch each other. Bed sharing is a type of, co-sleeping, but co-sleeping also can be just room sharing without bed sharing. So when people say that pediatricians don't want babies to co-sleep, that's not true. We want people to be in the same room with their babies, but not on the same sleep surface. Because room sharing without bed sharing is much safer than having the baby in a separate room, and is definitely much safer than bed sharing with the baby. Parents bed share because it's convenient for feeding, whether you're breastfeeding or bottle feeding, bonding. There's this belief that if you're vigilant, that you can keep bad things from happening to your baby. So the best way, so parents think that they can be most vigilant when they're sleeping with their baby, because I never really fall asleep when the baby's in the bed with me, okay? But I can tell you that's not true. And it's often, and because of that whole idea, it becomes a safety strategy for parents who know that they're doing things that they're not supposed to do. So if a parent is putting the baby on the stomach, they're more likely to bed share with the baby because they want to watch the baby. And we know that that's a disaster. And then there are parents that worry about environmental dangers. They worry about gunfire. They worry about rats. They worry about things like that. And they think that having the baby in the bed with them is going to keep their baby safe. There are a lot of things that are a problem with bed sharing. And I'll show you a couple of pictures, I think. The biggest thing is that the rates of suffocation and strangulation and entrapment in bed sharing is just unbelievable. So this is a baby. It's a mom's first baby. She's breastfeeding the baby. The dad has older children. The baby's 6 weeks old. The mom goes out and says, please put the baby in the bassinet. The dad's worked all day. He's tired. He had 1 glass of wine with dinner. So he falls asleep even though he doesn't mean to. And then the baby rolls over onto the bed and suffocates. And the bassinet is on the side of the bed, and you can't see it. This is a mom who has 6-year-old twins who's spending the night at grandma's house. She's been on a trip with the baby, returns home very tired. There's a crib in the room, but the mom wants to cuddle. And so they fall asleep, and in the middle of the night, the mom wakes up, and she can't find the baby. And the baby has become entrapped and has died, okay? These are normal people. These are well-meaning parents. These aren't bad parents that this happens to. This is a mom who breastfeeds twins in a recliner every single night, because she wants to be ready whenever either the babies wake up. And so the babies are 2 months old, and mom has done this every night since they've come home from the hospital, and so she thinks that this is safe. And then the next morning, when she wakes up, one baby has fallen back behind there and has died. There are 2 cribs in that home. Neither of them had been opened yet. They're still in the boxes. So we want babies to room share without bed sharing. We know it decreases the risk of SIDS by 50% and is more likely to prevent suffocation, strangulation, and entrapment. And it facilitates feeding, comforting, and monitoring. We do not recommend the devices that are promoted to make bed sharing safe because there's no data on them. You can bring the baby into the bed to comfort and feed, but then when you're ready to go back to sleep, just put the baby back in the crib. There are a lot of people that say that there are safe ways to bed share. There may be safe ways to bed share. This is a study that was published this year, showing that if you are a smoker, your risk. So this is no risk, okay, and this is lower risk. So if you are not a smoker, then you're bed sharing, then your risk comes down to 0. when the baby is 24 weeks of age, so about, 6 months of age. Is that right? Yeah, 6 months of age, okay? If you are a smoker, your risk never comes down to 0, okay? Bed sharing increases the risk of almost any sleep scenario. I often get asked the question, what if you're breastfeeding? What if you're not a smoker? All of that kind of stuff. If you add bed sharing to that, if the baby is less than 3 months of age, bed sharing always multiplies your risk 5-fold, okay? And then you can, and if you are over 3 months of age, it doesn't really increase the risk, but definitely under the age of 3 months, five times. And most of the families that are bed sharing with younger babies. Those are the ones that we're most concerned with. I'm not saying that you can bed share once the babies are 3 months, but the risk does go down a little bit, and so I'm a little bit less concerned about it. But things that make bed sharing especially dangerous, again, the smoking, excessive soft surfaces, sofas, armchairs, water beds, those are horrible. Pillows, blankets, multiple bed shares. If the parent has had any alcohol, if the baby is less than 2 or 3 months old, no matter if the parent's smoking or not. If the bed sharing occurs when the baby doesn't routinely bed share, if they're bed sharing with someone who's not a parent, including siblings, and if they're bed sharing all night long. I'm not going to talk about breastfeeding except to say that to do it, and that the risk of bed sharing does, and I already talked about that, but even though you're breastfeeding, that doesn't mean that you should bed share, because the risk of bed sharing is more than what you gain, the decreased risk that you get from breastfeeding. Pacifiers, again, do it. And that's it. I apologize. It was kind of a rush thing. But thank you.